Only 5% of all violent crimes can be attributed to some kind of mental health diagnosis. Yet, we see movies upon movies and all of these various shows depicting people with mental illness committing some of the most lethal violent crimes. And not only are these depictions horribly inaccurate, they're incredibly dangerous. And that's because people with certain mental health diagnoses, serious mental health diagnoses, are up to 10 times more likely to actually be the victim of violent crimes themselves. And for that and many other reasons, I decided if you go to my own page, you can see that I have a playlist titled Stigmatized Diagnoses to where you can learn and get more information about certain diagnoses that often have a negative connotation to really understand and create some kind of empathy. And this video will be one of those. And so today we'll be talking about trichotillomania, what this is, what this is not, and yet again, a horribly dramatized version of this, even coming from one of my absolute favorite shows. So before we jump in, I just want to introduce myself. Hi, everybody. For those that don't know me, my name is Sabrina. I'm a clinical psychologist, and on this channel, I talk about psychology as we see it in various Netflix TV series and films. Today, I'll be talking about one of my absolute favorite shows to exist, probably, honestly, top 3, if not my favorite, in terms of Criminal Minds. And it used to be on Netflix, but now you can watch it on Paramount Plus. But again, Netflix does not pay me or sponsor me, so I can literally do whatever I want on this channel. And so I actually want to start by talking about the show itself and how they depict this diagnosis, trichotillomania, in the show, and then we'll discuss kind of what it actually is to see those differences. And so to explain a bit about the show, for those that have, for some reason, never seen Criminal Minds, what this is that it has the main protagonist who are a part of the FBI's Behavioral Analysis Unit, the BAU. And so these folks use psychology as well as the evidence to kind of create what's known as a profile for what they call an unsub, which is the unknown subject, which is just the perpetrator of whatever crime they're looking at. And so based on certain evidence they're finding, they might determine certain things like the gender of the person or even the age of the person or just specifics that can help narrow down who the police might be looking for. And they always provide this profile to the actual police, but they themselves go out and capture these criminals too. So in this specific episode that comes in season 10, it's episode 9, we have a woman who is the unsub. Her name is Ellen, and she is going around offing people, and she got into a serious car accident a couple months earlier. And so because of that, she got a traumatic brain injury, which resulted in a diagnosis, what's known as intermittent explosive disorder. And so while that, I guess, is the impetus for a lot of the crimes that are committed, she's also shown to have trichotillomania, that they were finding these kind of hairs left on the scene. And then we even see her pulling out her hair at certain points in time as well. And her family is completely unaware of this because obviously she's hiding it from them. And because she also wears a wig. So even her husband hasn't actually seen her hair and this hair loss that she has. And she only really engages in a lot of these behaviors when she's in secret. She doesn't actually do it in front of her husband. So that's what we see in Criminal Minds. But let's actually talk about trichotillomania and what the DSM-5, which is a diagnostic manual we use to diagnose mental health disorders in the US, what it actually says about this diagnosis. So to start off, let's talk about the symptoms that have to exist for a person to be able to get a diagnosis of trichotillomania. The first thing is that, and most obvious, is that a person has to engage in some kind of hair pulling that results in noticeable hair loss. And we see that in Criminal Minds, where Ellen, we can see clearly the patches in her head that it's noticeable, this loss of hair that's happening. Now, as opposed to what's showed here, a lot of people can pull from their scalp, but really, we have hair all over our body. So this might not just be the scalp that the person's pulling from. It could be the eyebrows, the eyelashes, it could even be armpits, it could be pubic hair, which sounds extremely painful, but it could be pubic hair. And for people who just naturally have more testosterone, it could also be your beard and or your arms and legs. So really, it could be pulling from anywhere where there's hair. And so what this means when we think about this too is that it's not always going to be so dramatized as we see it, or dramatized. I'll probably say dramatized. I don't actually know if that's the word, but hey, I'm saying it, whatever. Anyway, it's not going to be as dramatic as we see it in the show. There's this one instance where she's in her car, and that's because after she offed her boss who really ignored her one day, she stole her idea, so she got upset and decided to off her. She sees this kind of memorial image to her as she walks in the office. She turns around, she can't take it, she goes to her car and then engages in this hair pulling. What we see is in one swift motion, she pulls out a huge clump of hair, and that's it. The whole thing is done. I'll talk about why it's incorrect for a number of reasons, but one of them is the fact that it's not when a person does this, they're not pulling out huge clumps at a time. I mean, even thinking about the specific parts of our body where we don't have that much hair, right? Like the fine parts like eyebrows, eyelashes, a person usually it's like pulling out a strand at a time, and they do this repetitively, repeatedly, which is one of the next symptoms actually that we'll talk about, but it's the repeated pulling of the hairs. And so this is also inaccurate. It's not really going to be a clump. Throughout the show, they do talk about how they would find like a strand or two strands at the crime scene. There is one time that they did find a larger clump as well. So again, it's not so dramatic. Like the reason they have this noticeable hair loss isn't necessarily because they're pulling out clumps at a time, but the consistent pulling in one session too. So in one session, a person could sit and individually pull out 10, 15, 20 strands of hair. Hopefully that nuance, that differentiation makes a little bit of sense. So the next is, which really this goes in line with any addictive kind of behavior, are the repeated attempts to stop. The person has really tried their best to reduce or stop it altogether, but they have failed. And even if they are successful, this person will experience chronic relapses. And I want to talk about the term relapse because there's a lot of stigma around that, and I feel like a lack of understanding, and we only really talk about it most times when it comes to drug or alcohol use. But when we think of a relapse, what it means, the actual definition is a person that suffers deterioration after going through a period of improvement. So when we think about it, all of us have experienced a relapse in some regard. I mean, think of how many of us said we were going to, start a new diet or exercise plan or any of our resolutions for New Year's, right? And then maybe we do well for a period of time, but then maybe for a period of time, for days or weeks, we regress and we go back to our old behavior. This is a relapse. And for any kind of chronic condition, so things like cancers or even asthma, things like that, it's expected that a person experiences these relapses. So I kind of want to destigmatize that. It doesn't necessarily mean failure. It can be a setback, but it's to be expected, and a person can hopefully learn from this and then go forward from there. And so those are the main kind of two symptoms. We'll jump in a little bit in terms of specifics around the pulling and things that go into that, but in a larger scale, those are kind of the main symptoms, but also it has to cause some kind of clinical distress or impairment in functioning. This is the case for any diagnosis in the DSM. Like if a person is just simply not bothered by it, then can't really diagnose them with this, but it has to cause some kind of clinical distress. And so that could be a person with this kind of hair pulling. Maybe there is social avoidance, especially depending on where you might be doing it. If it's very visible, there might be a lot of social avoidance because of this. There's a lot of shame, crippling shame this person's experiencing. Maybe it's really affecting their relationships, whether that be at work or with themselves. And then they're often doing things like wearing hats or wearing wigs, like we see in Ellen's case, right? That she bought actually a lot of different wigs. And so wearing wigs or makeup to try to hide what's happening, to hide this hair pulling. And it's not attributed to another mental health diagnosis. For instance, some common ones could be things like psychotic disorders. If a person has delusion somehow around these hairs, like maybe they have a delusion that somebody implanted these hairs in their body and they're pulling it out because of that, then we would diagnose them with psychosis, some kind of psychosis versus actual trichotillomania. Or if it's related to body dysmorphic disorder, maybe this person is kind of pulling these hairs because they think they look poorly in an effort to actually to fix their appearance. So it also can't be related to that. I mean, trichotillomania is kind of really exclusively unrelated to how a person looks in general. They're not doing this for that, and we will talk about some of the other motivations behind why they're doing this, but it's not at all to fix cosmetic appearance. Another thing is autism. In autism, a person might have, or people on the autism spectrum might have certain, we call it stereotypies or certain stereotypic behaviors where they might just do certain repetitive behaviors over and over. So it could be related to that too. Another thing to consider is OCD. And this one is a big one because trichotillomania is actually classified under the umbrella of obsessive compulsive disorders. So OCD itself. And this can be extremely hard to parse apart, like extremely hard to parse apart because in OCD a person might have either obsessions and or compulsions. So maybe they do have a compulsion to pull the hair out, but usually what you do to kind of differentiate is usually with these compulsions there's some kind of belief around if they don't do this something bad is going to happen. Versus, and we'll go more into depth later, but versus with trichotillomania where a person it's done because of a rising kind of tension and stress almost to relieve that in a sense like a coping with these kinds of strong urges or emotions that they're having. Again, it's a very fine line, pretty nuanced, but you'd really want to go into the motivations behind why a person is doing it. And so those are some things to look into to check and make sure that it might be true trichotillomania versus something else. So next I want to talk about kind of common symptoms that a person might experience and like go into the weeds. So the first is what's known as automatic pulling, and this one is out of a person's awareness versus a more focused pulling where this is in a person's awareness and as it sounds, they are kind of focusing and specifically doing this behavior with intention. So with the automatic, this pulling can occur while a person is doing other things typically. So maybe they're watching TV or they're scrolling through their phone or they're even studying. Like a person doesn't realize this is happening until after the damage is done. That one's not as common as the more focused pulling. And so this is intentional. This is often triggered by things like anxiety or boredom or perfectionism or really strong urges that a person might be experiencing. And this is often ritualistic in nature, which is why it doesn't happen as much automatically, although it can. And so, what kinds of behaviors that might be is maybe a person really takes some time searching for just the right hair, like finding a hair that looks like it'd be a good one to pull. Maybe they take time inspecting the roots if it is on the scalp. Maybe they, once they actually pull the hair, might even rub it in their hands, rub it on their face. Some people even eat the hair, which is known as trichophagia or phagia. And that is, again, the eating, specifically the eating of the hair. And that can result in what is known as trichobazor. These words, so complicated. Another term for that is what's known as Rapunzel syndrome. And what that is basically a person will develop a hairball like mass containing indigestible hair, not that hair's digestible, but indigestible hair, food, and mucus that would stay either in their stomach or their intestines. Think about with your hair too, as it starts to collect in the drain, and then when you pull it out, it's not just going to be your hair, it's going to be all these other things. Because same with us as we're eating and all of that's mixing together with the hair for the person that has trichophagia and is actually eating them. Over time, this will mix together, but this can result in things like abdominal pain, vomiting, weight loss, in severe cases, obstructions or perforations. And so this is another consideration too. This typically actually happens in younger people, so adults aren't as much at risk for this. So adults with trichotillomania don't typically do this full eating of the hair. People might bite the hair, for instance, but not everybody would eat it. So that's also some associated behaviors as well with the hair pulling. And in general, like I said, why this kind of occurs is because before a person pulls the hair, there will be this kind of rising tension, this intense, strong urge that they feel, almost like an itchiness in a sense. This urge really feels irresistible to do this. And so then when they actually engage in the pulling, they can get a sense of relief or gratification or even pleasure because there actually is some dopamine being released in that, just in terms of satisfying that kind of tension. So they feel this relief in the moment, which that loop is actually what keeps the behavior going. Same thing with addictions. When you start to have the urge and then you actually use and then momentarily you feel better. But as we know, there's always the after. So then after pulling, a person would start to feel those experiences or those feelings of like guilt and shame and regret. And that's where the behaviors like attempting to hide the damage comes in. Let's talk about some risk factors, who's more likely to have these, and just what goes into this. So in general, what we see is it's actually much more common in children or adolescents and younger people. That's often when it actually should start. And so with Ellen, for her, it seems like this behavior from how they're describing it, it seems like it started in later adulthood. And again, it's not that it can't happen then, and they're seeming to indicate that it happened because of this accident that went on, which potentially, I mean, yes, in a sense, that could be maybe a risk factor for IED that we talked about, but for that to be a cause of trichotillomania, there's no real research that shows that that would cause that. So again, it's more prevalent, often starts in adolescence, but can start even younger. Typically, in terms of gender, the rates are equal between men and women in childhood, but then as adults, much more common in women. It's often more common in people who have some kind of trauma history, which, if we think about this, that really throws off our ability to regulate emotions and to tolerate distress as well. And so, being able to actually, when you have those strong emotions that come up, being able to manage them yourself without having to engage in this case, what is like an external behavior to release that tension, that system really gets disrupted. And then just the ability in general, when you have uncomfortable emotion, to just be able to tolerate it, that system also gets disrupted because of trauma. There is some evidence of genetic kind of vulnerability. And so people who have certain other disorders, it's common to occur with these too. So people who might have OCD or anxiety or Tourette's, that often we see that this might be a contributor to also getting trichotillomania over time. And it is one of those things I talked about comorbidity. And so what that means is having more than one mental health diagnosis at the same time. And majority of people, it's almost 80%, it's like 79% of people with trichotillomania have a comorbidity. They have another diagnosis. Usually that's some kind of mood disorder, so anxiety being one of the highest. And then we have depression, but it can also coexist with things like OCD, like I just mentioned, things like PTSD, talking about the childhood trauma, and then some neurodevelopmental diagnoses. So, for instance, ADHD is kind of a common one, which we think about it, that makes sense because of like impulse control. But in general, too, for people with impulse control, struggles with impulse control, they might also get this diagnosis. And so, going back a little bit to history, in the DSM, trichotillomania actually used to be put under the category of impulse control or other impulse control disorders. It didn't change until the DSM-5, and the DSM-5 came out in 2013. But this episode of Criminal Minds came out in 2014, so pretty soon after this change, there might have still been thought, or maybe they didn't realize that it had changed to be more like OCD versus a true impulse control disorder. There is a difference between the two. And so with intermittent explosive disorder, that is also under impulse control disorders. So I could see from that perspective why they might mistake the two and say that her having IED, that it would make sense that she would also have trichotillomania because she lacks impulse in one area, so then maybe lacks impulse control, in one area, so then maybe lacking impulse control in another area. But again, that has changed to really acknowledge the fact that it's not really an impulse control issue. This is a method, a way a person is trying to cope with distress in terms of the hair pulling. So yes, they've tried to stop and cut down on the behavior, and in that sense, it is impulse control, but it's not just, I just need to stop doing this behavior and that's it. No, it's, I need to learn how to cope with the things that are making me want to do this behavior in a different way. And I know I've mentioned a lot, and I actually should have mentioned earlier that I won't talk in depth about intermittent explosive disorder in this video. If you're interested, I'll link it kind of up there, up somewhere. And I just learned this recently, but when I link videos up top, it actually goes in the description box too. So if you don't want to click it while you're watching this, again, it'll be in the description too that you can watch after. But I did a video on the film or the Netflix series The Gardener, and this dealt with a person who, when they were a kid, got in a serious car accident, and because of that, they lost their emotions because of where it hit in the brain. And so in that video that I did, I talk about the popular case with Phineas Gage, where he had this metal rod that went up through his skull, and how that resulted in a lot of changes and some things related to impulse, but could also relate to some things like personality. So if you're interested in that to see kind of how realistic this aspect of the IED and a brain injury could be, go ahead and watch that video. But anyway, returning to this video now, trichotillomania. So I mentioned there was some potential genetic vulnerability, some comorbidities that can happen. And just on a neurobiological level, it's seen that a person with trichotillomania, their circuitry is pretty similar in the brain to things like OCD and addiction. When we think about the reinforcement, if a person is struggling and is stressed out about something or needs to deal with the situation, so maybe they take a drink and they feel better temporarily, that is powerful in our brain. So it associates that behavior. It learns that, oh, okay, this works. So now I'm going to keep doing it. Same thing, if we're feeling such a buildup, such a tension, like imagine a soda bottle that if you shake it up all the way, like that tension that can be rising, and we don't have a way, like we don't have any skills, emotion regulation skills to be able to release it, doing something like the hair pulling might be a way to let the cap off for folks with trichotillomania. And so then the brain similarly learns, oh, that worked. Okay, I momentarily felt better. And yes, I feel a lot worse after, but our brain isn't going to really file that part. It's going to file the part of I was in a lot of distress and I did this thing and now I feel much better. And so really when it comes to treatments, the thing to note is that there's very little efficacy. Research has found very little efficacy for just medications alone. Medications with therapy can definitely be beneficial. However, a lot of folks find a good bit of success just through therapy. And so if this is something for you or your loved one that you are wanting them to get treatment for, definitely suggest going to like a psychologist, somebody who engages in more talk therapy to help through this. And the gold standard for therapy is a treatment, what's known as habit reversal therapy, or just HRT. It involves 4 main components, and this is found to be super successful, not just for trichotillomania, but these other kind of similar repetitive negative behaviors a person wants to change. So it's even used for things like smoking cessation or things like nail biting, for instance. Could also be used for excoriation, which is skin picking. I didn't talk about that in this video really, but the two often really go hand in hand. I forgot to mention it during the comorbidities, but basically all the things that I mentioned for trichotillomania, you can put towards excoriation. So instead of the hair pulling, it's just kind of the skin picking. So in terms of the various components, the first is what's known as awareness training. So getting a person to actually be aware of what their triggers are. And because this is such a ritualistic behavior, there's often consistent patterns that a person sees, whether that's certain emotions or certain situations. So really knowing what those things are that's going to set them off. And that's the first step for really any other addictive behavior too. That's what I often will talk with my own clients about working in a substance abuse rehab center. I'll often talk with them about this too. That's the first step. Be aware of what your triggers are. The nexus was known as competing response. So what this is that this is a voluntary kind of behavior that competes with the behavior that you're wanting to change. So for instance, in this case, hair pulling, and you want to do this almost immediately after you feel the urge. And this is something that can substitute for that behavior, but is also, it makes it basically impossible to do the thing like hair pulling. And the goal is for it to be something that's socially inconspicuous. So it shouldn't be necessarily obvious. That way, whenever a person has an urge, they can engage in it in the moment. And we want it to be an action that's sustainable enough that a person can do it for anywhere from 60 seconds to like 3 minutes until that urge subsides, because our urges truly only last a few minutes if we let them. And so doing a behavior that a person can actually hold that long. And so what that might look like if it's hair pulling or skin picking, when the person feels this urge, maybe instead they clench their fists. They clench them really tight, or they even might like sit on their hands, hold a small fidget toy. That way, in that moment, it's impossible for them to complete the behavior because you need your hands to be able to pick. So if they're occupied with something else, they're not able to complete that behavior. Same thing with things like smoking, right? Or even nail biting. A person might clench their hands. Maybe they fold their arms, or they grip a ball, or they grip a pen really tight, something like that. So you first want to figure out what your urges are in the moment that you're having this urge, basically right away engage in a competing response so that you cannot complete the unwanted behavior. And then we want to help this person even further by engaging what's known as stimulus control. So making it even more difficult for them to engage in this unwanted behavior. So if it's hair pulling, that might be things like wearing gloves. It might be wearing certain hats and other kinds of barrier methods. And yes, I know that I talked about the fact that a person has a lot of shame around this and that this could draw a little bit more attention and the other actions that we're discussing were a little more inconspicuous, definitely understand. However, it can be really difficult for a person to still, even with things like clenching your fist, for that to be kind of enough. And so, especially for the person that does these behaviors kind of automatically, and so finding barrier methods, and there's ways a person can work with their therapist to figure out things that are comfortable for them. So maybe they don't feel comfortable wearing gloves, figuring out other things that they can do. And then what we want to do as well, one of the last things is emotion regulation skills. Being able to actually find other ways that's not doing this behavior that a person can learn to manage these strong emotions that are coming up. And so that could be things through like DBT, dialectical behavior therapy, which has entire module about emotion regulation as well as distress tolerance. So if a person is in strong distress, like Ellen was in the moment when she saw her boss, for instance, not needing to resort to doing this behavior, but having another method of internal coping that they can utilize. Also, CBT is a great one. They have certain treatments. So, for instance, in CBT for substance use disorders, so CBT SUD, there's what's known as urge surfing. So, this helps a person with really unwanted behaviors. They can use it for gambling, if you have urges to blow up on people when you're really angry, urges for kind of any addictive behaviors, and things like trichotillomania is kind of figuring out that urge as it comes and learning how to ride it out versus engaging in that behavior. And so that's why things like medication doesn't actually teach you the skills to help with emotion regulation and those other things that you need. And so I just want to end by touching back on the kind of movie, TV, media depictions of these things. In a sense, it can be helpful because episodes like this, at least for what I could remember, especially at a time like 2014, this was the first piece of media I had ever seen on Trichotillomania, and I think still to this day maybe have ever seen on it. And so it really helps to kind of raise this awareness as well and maybe start conversations about things that a person might be struggling with, might have felt uncomfortable to bring up otherwise, and maybe get the help in learning impulse control skills or emotion regulation skills. But then it can be incredibly misleading and unhelpful because it can link to or cause this kind of association in people's brains, false association, that now this can connect to violence. Even things like intermittent explosive disorder, where yes, that person, a big part of it is engaging in like violent acts, but going all the way to offing people is not likely. So even then, it's still a dramatized version of it because it's not exactly what's happening. And so in the show, Trichotillomania is used as like a plot device basically to give a kind of more visible external symptom which helped them to deliver this profile and a kind of clue into mental instability. When again, for folks that might not be the case. Like having trichotillomania doesn't necessarily mean a person is mentally unstable. It just means they're really struggling and haven't quite figured out how to deal with certain emotions or certain distress. And so they're coping in a maladaptive way. And when the person learns the tools that they need to cope in an adaptive way, we see them adjust well. And so, again, no, it's not necessarily linked to mental instability. And it is not, absolutely not, I want to reiterate, not predictive in any way of violent behavior. But even things like suffering a traumatic brain injury, which I talked some about in that other video too, suffering a traumatic brain injury, that's also not like indicative of a person becoming then homicidal. So hopefully this just helped you to get a little bit more knowledge about an otherwise unknown and misrepresented diagnosis. And I really encourage you to look through the rest of my stigmatized diagnosis playlists, and maybe there's other ones that stuck out to you to just get more knowledge about other ones. Because like I said at the beginning of this video, and I truly mean it, lack of information and misinformation is so dangerous. So, yeah, hope this was helpful for you and that you learned something new today. And if you did, please share this information with somebody that you think would benefit from it.